the internet works and we have technology. So I'm Mark Olaf. I am from Geisinger Commonwealth School of Medicine, Geisinger Health System, based out of northeastern and central Pennsylvania. I'm here to talk today about some events that we had happen on our campus that were rather tragic, but also putting that in a broader context about challenges that we face in healthcare regarding violence. In addition to my role as a vice chair of emergency medicine education, I'm also, we have a regional campus-based medical school, so I'm a regional associate dean for the campus. And our campus is based in Danville, which is our kind of flagship hospital, 500-bed plus tertiary care center, level 1 trauma, all that kind of stuff. And in addition to my background in emergency medicine and medical education, I'm a former firefighter and EMT. I trained at the National Fire Academy and the Center for Domestic Preparedness in the past, and I think that just informs a little bit of my perspective and take on how to approach some of these challenges and these problems. I don't have any conflicts that relate to the topics I'm going to discuss today, but there are a couple of commercial products that I'll discuss, and we do use those in my workplace, and just more of a sense to share those resources with you if you've never heard of them, just as a point of reference and something that we're doing to mitigate some of these things. So the broad context is that violence in healthcare is really a big issue. You can see among different industries in the United States, healthcare and social assistance has the highest number of injury and illness cases by far. In addition to this, it's recognized by a number of entities. So one of the entities that recognizes this problem is the U.S. Department of Labor and the Occupational Safety and Health Administration, OSHA. They know workplace violence is recognized as a hazard in the healthcare industry. Academic institutions recognize this, so the AAMC recognizes that threats against healthcare workers are rising, and even our scholarly publications, New England Journal, is publishing on this topic. It's of critical importance. And not just related to industry and academics, but certainly accrediting bodies like the LCME actually asks us to ensure the safety of our students when they're on campus. So of course there's an LCME standard 5 and 5.7 specifically that says, as a regional dean or as a medical school, I'm responsible for ensuring the safety of the students on my campus. So what does that safety look like? Well, if I look at my campus or my medical school, if I just look at emergency department injuries, these are our different campuses listed there in the table, divided a little bit out further than we actually have in our medical school. But you can kind of see a number of ED visits, number of injuries related to that. And in 2023, we had 76 staff members who were injured from intentional assaults committed by our own patients, of course. Incidence rate's about 2.4 per 10,000 patient visits. And the places where most of these are happening are at two hospitals, GWV and GMC. GWV is located in Wilkes-Barre, Pennsylvania, which is a moderate-sized city, and GMC is where I'm based. Very small town. It's a place. We can have a separate conversation. It's almost a place that shouldn't exist. We have a 500-bed hospital in a town of about 5,000 people. But those are our two tertiary centers, and that's what's driving most of this, it seems. As I was thinking about this talk and exploring this concept and figuring out how we can share information with others so that you can protect yourself, protect your students, create a better workplace, I was able to connect with our own security folks at Geisinger who were incredibly forthcoming with information. I was very worried that I was going to hit a brick wall and say, we don't want anybody else to know what's going on. It was quite the opposite. I wound up with a whole bunch of resources and PowerPoints and data, too much that I can't even share it all. But I've highlighted a couple of pieces here for you. These are the graphs that we're seeing at our institution, so confrontational events over 2 years, absolutely on the rise. The chart on the left there, or on your right there, the blue is 2022, so things were rising. In 2023, it's hard to say that that's a very good predictor line because it's kind of all over the place, but perhaps a little bit on the downtrend, but certainly we've seen some changes over the past couple of years. In our own emergency departments in 2023, we instituted a metal detector program, and we never had this before. We didn't do routine screenings with security or anything like that. We certainly have some locked doors and things like that, but we didn't have this in place. It was really quite enlightening to see what our security services found. So you can see there the number of firearms, 411 that were found on persons coming into our emergency department that previous to this just never would have been detected unless they had offered it up or if it was holstered or carried in a more open fashion. Of course, we would occasionally find some weapons and things like that on folks that come in as on traumas or patients as we're changing them out of their clothes and things like that. But this is, I think, just an enlightening set of statistics for me. So the thing that got me thinking about all of this was, quite frankly, a very tragic incident that we experienced on our campus. So on December 30th, 2021, the night before New Year's Eve, I remember very specifically where I was. I was at home with my family. We had some friends over to the house. We were, just having some dinner and things like that. And I get a secure message. We use Tiger Connect. I get a Tiger Connect from my department chair, and he had sent out kind of a blast message to the ED doc saying there was a shooting on the Danville campus, and certain parts of the hospital were under lockdown, and security was going through their procedures. Everybody kind of stay where you're at, but we're just letting you know. I said, okay, so keep that in mind. That came from my department chair. That didn't come from security. That didn't come from some emergency management system. That was just that, and that was me as a physician learning that. I sat on that information for just a little bit and then thought to myself, well, in my capacity in emergency medicine, this seems to be covered. My chair's got this, security's got it at the hospital, but what about my medical students? Now, we're on winter break. My third-year students, core clerkships, conceivably all home, but sometimes people use that winter break for some rotations, exploring things. I don't know, maybe they're there, maybe they're not. Of course, all of my staff that helps manage that information, also home. This was a Friday night, I believe, so they're home on holiday, all that kind of stuff. This is occurring well after 5 o'clock by the time it's landing in my lap. How am I gonna figure out which students are there? And does anybody else at the school know that this is happening? I'm a regional campus, but there's some leadership above me, and I didn't get this information through some singular channel. So I give my my vice dean a text message and say, hey, just heard about a shooting, can I call you? And he doesn't give me the option to call him, he calls me, right? I said, hey, here's what I know. He said, nope, I don't know anything about it, let me talk to the dean. He calls the dean. That was how the dean found out. So that was just an interesting kind of turn of events there. And you'll kind of see, and if you've been in the unfortunate circumstances to ever have been around an event like this, or to have observed it or have taken part in the after action kind of debriefing and planning, you'll realize very quickly that a timeline like this and the sequence of events I just described is actually super common. These things don't go as well as anybody plans. I think one of the things that gets talked about quite a bit, I do a talk on organophosphate poisoning for our residents. We talk about the Tokyo sarin attacks as a case study in mass casualty incidents. The first people to come to the emergency department are not the ones that are coming by ambulances or the sickest or anything like that. It's a lesson in triage, it's a lesson in disasters. And that's what happened here. So at 5:12 on this day, security notified of a shooting near one of our office buildings on the campus. 5:17, security contacted the 911 center and their coordination with law enforcement began. 5:21 p.m., nursing supervisor was notified of the event via an off-duty staff member, so they're getting this not through normal channels or expected channels maybe. 5:37, so we're 25 minutes into this, a code orange, which is the lockdown signal for our facility, was called, and that was an overhead page accompanied by that. And then there's a code silver, which is an active shooter, was actually followed 3 minutes later. Encompass and Pine Barn are two separate entities that physically are just, not even 100 yards separate from the hospital, but are different entities. But an hour later was when folks on those, so they're functionally on the same campus, but they found out an hour later that something was going on. At 6:48, VOLO is our disaster emergency medicine or emergency management messaging system. So a full hour and a half after this event began, and well after, folks in the know were involved in addressing the issue, at least a full hour after that was when messaging started to actually go out to employees and staff to let them know. And then by 9:31, a final sweep of the facility. And this is just a really broad overview. In some of those time frames, Other local hospitals were made aware. A neighboring hospital that's about 20 miles away found out, and they actually went down on lockdown. They had no physical threat close by or anything like that. They decided, like, we're shutting down, which created a really unique circumstance for EMS. Because if your ED's on lockdown and you don't actually have a threat, and the place that is the tertiary center is on lockdown and can't take an ambulance, now we've run into a couple of issues. So there's some practical challenge there. Around 8:40 at night, the FBI was involved, and it was almost, it was around 8 o'clock that night. There was a joint information center that was established between the coroner, law enforcement, and media to communicate the ongoing events there. So that's not unique to any, that is the case for all of disaster events, right? Things don't go as planned. And that's some things that we can kind of learn and anticipate, right? So we can draw up a plan, but we should anticipate that it's not going to go because it is a disaster. And by definition, we've exceeded our resources when we're encountering a disaster. So a couple of things that came out of this from our security and emergency management services to think about. These are our areas of concern. These are things that we wish we could have done better. One was communication. You saw it was like an hour and a half where employees were kind of getting to know something. I will say in that timeline, it's very anecdotal, but I think it's very telling of that kind of poor communication or challenging communication, and a bit of a challenging in the policy application that you see there. We had food services workers on campus, right? Of course, right? Patients need their meals. Well, the food services workers said, code orange, that's a lockdown, I need to go hide. And then code silver, there's a shooter. I'm gonna hide somewhere secure. Where'd they go? Into the cooler. Probably pretty safe. If I'm a food server, like if I'm anywhere near the thing, that's probably it, right? They stayed in there for like an hour and a half. Fortunately, no one got like hypothermia or anything like that. That was good. But in the events that unraveled after that, no one else knew that they were in there. No one else knew that they were in the building anymore. As things began to lift, they were still in there. Messages weren't kind of coming through and were coming in a delayed fashion. And then in the hours following that, this was dinner time. All of the patients in a 500-bed hospital, every meal was delayed that evening. Now, end of the world, probably not, but you can imagine how disruptive that really is to patient care. And putting things in context, it's not the biggest, but it's just an anecdote of some sequelae of having some perhaps not best policy applications. And that also kind of highlights a familiarity with safe spaces. Was that probably a safe space? It absolutely probably was a safe space. And how familiar is security with the appropriate safe spaces and the employees in their area. And then it was, for me anyway, we had very unclear academic expectations. So in the hierarchy of running the campus, I have nothing to do with clinical operations, right? I'm here to take care of the students, and everybody knows that I'm here to take care of the students. But this is a clinical thing. This is an emergency thing. Where do I fit in that? Where does anybody fit in that? And where does the dean of the medical school fit into all of that? She should at least probably be aware, right? So as we're addressing these things, one of the things that is super important to kind of point out about the lessons that we learned and also opportunities for us and for you to kind of think about these things is, one is communication. We have a lot of communication tools that we use on a daily basis, right? Everything, there's our Volo emergency thing. We use Tiger Connect all the time. Certainly phones and text messages, personal and corporate. Bless you. Microsoft Teams we use quite a bit. There's all types of kind of phone trees and communication chains there. Social media gets used, quite frankly, and in this case it actually was used. Some of that timeline that I didn't share with you highlights like when things were posted to social media and how that informed next steps in lockdowns and things. And then communicating among the clinical sites and among outside entities, I pointed out some of the challenges with that. Planning and knowledge. People had different concepts of what the lockdown was. It's supposed to be kind of stay in your place, but how close is my place? How far can I go before I'm out of my place? What happens during screening? Is a lockdown really a lockdown? Is it, because even when our security folks rolled this out, it was coming up on shift changes. 5, 6, 7 o'clock shift change, right? So understanding common definitions. And what they really found from that, from their standpoint, was our code orange, or our lockdown policy, was like a boilerplate policy that somebody had kind of found, thought a little bit about and said, we'll make this our policy. And they realized it's just too generic. It doesn't answer all the specific questions that we have for our institution. So that was one big point that we walked away with. And then the lockdown actions. So in food service delays, I mentioned, patient flow delays, same thing, are all the folks that transport patients to the hospital, discharge and things like that. And again, you put it in context, you say, if you had to wait 2 hours and you didn't get shot, so you got to go home to your family because you were being discharged, like probably okay. But it does build up into something to kind of think about. Other code delays, somebody had, a cardiac arrest that happens. I don't believe that actually there are anything major events here, but it's all certainly related. So what are things that we do to address this? Number one is prevention, right? We got to get upstream, right? This is, what we're talking about is pulling bodies out of the river. We need to get upstream and prevent these things from happening. We need to communicate better. We need to stay connected, and then we need to promote what to do in these situations. So don't bother with the QR code because I set it up and then I tried it earlier today and it didn't take me to the right place. But suffice it to say that Geisinger really wanted to actually promote some of this stuff so that others can learn from us. So we actually had our chief medical officer for medicine services for the entire system partner with the AMA and has gone out and spoken about this. So they're trying to get some publicity. There's things that we do internally, and these are things that are available, I think, to generally everybody in some capacity or at least an institution. So management of aggressive behavior training is something that our nurses in the ED get or have the opportunity for. I believe it's part of their training and onboarding. And we actually also, we have, in the past anyway, we have our students who are on their psychiatry rotation actually get this training, and this year we're actually starting to give them the physical in-person training or offer it to them as well. So it's something that they're kind of learning too. The magnetometers and screening at the entrances, you saw the importance of that earlier. And then this is Vicky with Aria, and Aria is a trained guard dog or police dog. I will say that, the rollout of Aria was kind of challenging for us. Aria just kind of showed up in the emergency department with Vicky and with others. Vicky's like her primary handler, but she's kind of showed up, and then, and she would of course show up when we had like a behavioral health patient that was being aggressive. And, a barking dog doesn't de-escalate a situation very well. So there was a learning curve with all that. And in that learning curve, we found out that we weren't initially told, she's actually trained like on explosives and firearms and has some attack commands that are in like German. So that was a long-term learning process, but as we've gone through that, we've learned a lot, and she ends up being a great benefit when she gets appropriately used. I learned something about our security services and all this. We use a product called Verkada, and I'm told that this is the same product that I think Delta Airlines uses. You might have gone through some TSA screenings where you stand in front of the camera, show them, right? You don't even have to scan your boarding pass. They just know who you are. Apparently this happens at work for me. Apparently it's on like we've got cameras everywhere. I'm sure you guys do too. But walking in from the parking lot, they just know who's coming to work and who's leaving. And our security folks, I changed MRNs and initials and stuff, but this was a person who was using multiple aliases for to try to get some opiates and things like that. But just evidence and proof that like these services are out there. Your institution might be using it, and I honestly had no clue until I started talking to our security folks. But another way to kind of prevent and manage safety. So put this in a different context, somebody that's known to perhaps be at risk or something like that could be identified much earlier and a threat perhaps mitigated. Communication. One of the things that we learned about this, and I should say, our security service, I think, were aware of this and the need for it, but it highlighted the importance of it, is duplicity and redundancy in communication in situations like this. So after this event, I realized I didn't have a connected way to talk to all of my students who might be on campus at that point without going through other channels, which used to be fine. So we created a Tiger Connect group, right? You could do the same thing with phone messages or WhatsApp or whatever you wanted. But we created a group, and that group gets updated monthly as we have students come onto campus and leave campus and things like that. And they get enrolled so that if we have an event like this, we can connect with them in a more urgent fashion. We've also asked our students to download this app from Alert Media. It's another commercial product. We've replaced our Volo system with this Alert Media product, and it actually has, as long as you turn on the tracking portion of it, it can actually figure out where you're at And that way, if we have an event on one medical campus and you happen to be there that day, the student gets the appropriate alert or the employee gets the appropriate alert, and you also don't get pinged with a whole bunch from different campuses. And then addressing that across campuses is a whole separate issue. And then our security services in 2019, I think shortly before the pandemic started, was offering ALICE training, which I've taken before, and it's a way to mitigate firearm threats in the healthcare setting. They'd stopped that since the pandemic for, I think, obvious reasons, but they realized they needed to re-implement that to help people deal with these situations. Another commercial product that we adopted is something called Strongline. You can see that the top thing there is it's a little device. It creates a wireless network. It plugs into a receptacle. You put these all around the hospital, which to me presents a little bit of a risk of somebody just pulling one out of the wall if you wanted to. But we all got these little devices here. And just attaches to your badge. And if you tap that twice, it's basically like a silent alarm, like a bank teller or your unit desk clerk would have. And security comes running, it sets off the code overhead. And it actually is integrated with Tiger Connect now, where it actually, they'll, because of the badge communicating with the network, they know where you are. And if the event is happening in proximity to you, you will also get an alert to say that so-and-so set off their device and they're near you. So you could also kind of run for cover if you needed to. The other part about this, of course, is connectivity and promotion. Like, people just need to know that these things are happening, so that's been something really big here. So overall lessons learned, communication is absolutely key and likely has barriers and challenges. You can't have a policy that's cookie cutter. You definitely it needs to be customized. And something that is all or nothing is not a best practice. That was the, code orange lockdown. Like, that didn't work very well. As soon as shift change started happening, we were still in lockdown, but they were doing enhanced screening. Well, that's not a lockdown, so can't be all or nothing. Training and sufficient resources are key. You have to have people aware of it, familiar with it, and then actually have those resources in place. And then there definitely need to be duplicative pathways here. So the take-homes for you, I think, are to think about these 4 categories at your institution. So if there's something that you want to do or be more aware of, it's to think about how is your institution working on prevention. Something that's probably mostly outside the scope of us as an educator or as an EM doc, but certainly in our best interest. And sometimes it's just nice to be aware of those things. Communication is the other part. How are you going to communicate with your colleagues, your learners? Is there a department policy? Is there a school policy? Being familiar with that. And that certainly relates to the connectivity aspect of it. One of the interesting things that our security services realize, like, we have all these corporate IP telephones all over the hospital. They didn't realize that even everybody in the hospital calls the operator to do an overhead announcement. Well, security found out through their process here that they could actually just get the phone number to do the entire hospital overhead. It was like, not really like a eureka moment, but for them it was kind of like a light bulb moment. Like, okay, well, that's a way that we can communicate with people, and we don't need to guarantee that there's an operator that's going to, transmit that. And then promoting these things. We have to be mindful of when to do this. Is it as new learners are coming in, if we're thinking about our learners? Is it every time we've got a new set of residents, onboarding of docs and things like that? So things to think about there. So thanks for your time. Sorry for the delayed start, running over a little bit, but happy to take questions if you have any. No problem.